on US Eagles and EMS World. We've gotten a lot of traffic and a lot of views from those areas. And as always, it's great to look forward to exciting conversations. So Paul, it's all yours. Go for it.
Okay, good. So a couple things are for the Eagles themselves. Make sure that I think the people that send it into, I believe, is Stein Bronski, is to make sure your up-to-date photos and bios are set in for your Eagles, the evolving website that we have. And again, remember everybody, we're not talking about social distancing, it's physical distancing because we're here doing our social closening. Thank you for being here. This has actually been fabulous for me to stay in contact with all of you and hearing what's going on. And so thank you so much. And also our sidebar conversations that we have in the evenings or early morning hours or whatever it may be. And again, I hope it's Taco Tuesday somewhere for somebody. So I hope it's a good day and you get it to go with your mask on. One of the things just an overarching thing is I am concerned that the so-called with the openings or loosening of restrictions that the public is getting a sense that, we're over the hump and it's a green light when it's still, what we did was suppress the curve and it's out there just as much. And the projections that we're hearing both,
AJ,
hey, AJ, you're live, okay? AJ, hang on for a second. AJ, you're hot, okay? So anyway, let me go back to it. So what I'm also seeing is that there's a sense that we're okay, we're over the hump, and I'm afraid we will get some resurgence, like we heard from Singapore last week, and and the predictions we're getting not only from say Hopkins or from Seattle's people that do this, or from the University of Minnesota and CIDRAP the other day, is that this is going to be going on for a while for us because we're not sure how much immunity is out there. So I would never let our guards down, and our messages to our local officials will be that this is going to be with us and beware. So I think I am concerned about this. In some respects, we were fortunate to get the Europeans hit hard first and New York folks because it got us, the rest of us, prepared. I'm sorry for what they had to go through, however, for our sake. So let's just keep that in mind. And the other thing we're going to talk about later today is that some of our loved ones, literally loved ones and great friends have been lost. And I just want to keep that from happening in the future. And the other thing everybody is seeing now, it's not just the elderly and somebody with high blood pressure or, other underlying things. We're seeing, kids, 17, 20-year-olds that in good health dying or close to death in many cases. So let's just hope we can keep that message going. So I'm Paul Pepe and I approve that message. So let's move on to what else we're going to do today. So originally I was going to start off with Mike Osterholm. He had told me he was going to be on for the first 15 minutes and I just got signaled that he is tied up in something else, I think with the governor there. And so probably is going to try to pipe in here, but probably will not be able to do it, I suspect. So I'm sorry about that. But if anybody, I think everybody's already heard from him because his group, the CIDRAP, which is the Center for Infectious Disease Reporting and Policy at the University of Minnesota, put out a statement last Thursday. I think we've all received it, predicting that this is going to be going on for quite a while, etc. Hey, by the way, can you see me okay, Craig, or any of the other folks that are out there? Okay, got it, because I'm not seeing myself on the screen right now. So, all right, thank you then. Okay, so with that, let's go ahead and take advantage of that to talk about a little bit about how this has hit home a little bit. And if you don't mind, hey, Rodney Turple, are you there by any chance?
I am, Paul. I'm here.
Yeah, so as a little bit of a background to this, Rodney, you can do a self-introduction of your position, but what I do want to say more importantly is that this year the Eagles were going to join up with a organization that is the Fire Chiefs Association of Broward County, who have been hosting a fantastic meeting for the last 2 decades. First of all, I was enamored of the title, which was First There, First Care, because that everybody knows me says that we don't treat or manage patients, we care for them. And that's always been my mantra. And I was enamored right away when I saw them entitling their conference First There, First Care. And the person who helped to get this started with a couple other Confederates, because way back in those days, was Rodney. And this year's meeting was going to be hosted at the Hard Rock Cafe Casino, or the Hard Rock Casino, I should say, and Resort in Hollywood, Florida. And that was all being arranged through Chief Don DiPetrillo. Don DiPetrillo was the fire chief for the Seminole Nation there and for the casino. And he was able to bargain a really good deal for us. And he was the head. In fact, the day he decided to stay home was Tuesday after we all had met at EMS today, and told me he wasn't feeling well. And so I kept track of him for a while after that. And I was that far from actually meeting him at a time when he was becoming ill. And unfortunately, after a very long period in the hospital, he in struggle, and we all stayed on top of this thanks to various people like Dr. Wayne Lee and Dr. Antevi and Dr. Katz and others and all the other chiefs. We unfortunately lost him a few days ago. And I mentioned this, I think, on the last call because we had just heard about it. But I did want to take a couple of minutes to say the person who is really integral in helping us and had met with people like Craig Manifold and Peter Antevi and Scott Gilmore just a few days before is now lost to us. And just wanted to say he was special to the Eagles and had a special role. So I thought Rodney, who was very close to him, might want to say a couple words if you could just, maybe about a minute or so, because I don't want to overdo this too much, but at the same time, I never want to leave it that he, was forgotten. That's all. Rodney, if you don't mind.
Yeah, no, thanks, Paul, and thanks everyone. It's an honor to be able to, we've had a passing of a couple of South Florida icons here, and we lost Don Shula, who's obviously everybody knows who he was, but Don DiPetrillo was just as much of an icon to South Florida as Don Shula was. Don DiPetrillo, we're talking a 50-year fire rescue service career starting. Dave had his pictures up on Facebook the other day with Don on a surfboard starting at the lifeguards position in Fort Lauderdale in 1970, and he worked his way up all the way through to an assistant chief at Fort Lauderdale Fire Department. That's where I got to know Don and meet him because I was a Broward County paramedic at the time. So both of the DiPetrillo brothers are very, 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 very influential in South Florida fire rescue and EMS. So Don left and retired, and how most of us are. We can't keep it out of our blood. He ended up going to his hometown where he was raised in Davie, just west of Fort Lauderdale, and became their fire chief and really got them going into the EMS part of it in the mid-90s. And spent about 8 years there, and then he retired again and, got right back. Somebody got him over there at the Seminole Tribe and got that whole fire rescue EMS department up and moving. Don, in short, was, if you didn't meet Don, it's too bad because he was such a wonderful, nice man. Bottom line, you've seen that in all the newspaper articles and everything that's been written about him this week. He was a really caring individual, salt of the earth person who we are so fortunate to have had him in our lives here in South Florida. So he won't be forgotten. There's going to be a lot of stuff going on. Obviously, we're going to rebound, and hopefully we'll be back at the Seminole for the first time next June. We've got dates. We're all going to sit down and start these conference meetings over again shortly. And I think the collaboration between the First Air, First Care, and the Eagles is just something very special. It's something Don wanted. It's something that I wanted. It's something that the whole conference committee wanted, and the community to be able to host such a great event. So say a prayer for Don. Also, real quick, say a prayer for, we lost a dispatcher yesterday, Nakima Thompson, BSO dispatch. We've now lost them, police, fire, dispatch. We're feeling the brunt of it down here, Paul, but we love you guys. Thank you so much for everything, and please do keep Don and his family in your prayers.
Thank you, Chief. I really appreciate it, and I thought it was really, and Craig Manifold, you got to meet him a few days before he got ill over in Tampa. And can you tell us what, first of all, your reaction was when you met him, and then secondly, what you're doing for him on our website?
Sure. Don was one of those folks you meet and immediately have a kinship and an affection for, in that he's well respected as Chief Chirple alluded to. Unfortunately, we didn't get to know him during that full 50-year career, but the short interactions we had with him were impressive. And our coordination with our meeting was really just something that was taking giant strides because of Don's interactions, his knowledge, and his relationships that he had at our venue site. And we had the opportunity to meet with him and kind of continue our planning process with that. And so he was a integral member of the Eagles and putting on the First to Care conference for us, and was excited and supportive and really was making things happen for us and opening doors that I don't think we would have been able to open without his presence. His interactions with us, again, although brief, were impactful. And so we're going to put up a banner on our Eagles website that will just recognize the impact that he had for us, and certainly with our thoughts and prayers that go out to his family. It's funny, Chief Chirple mentioned his surfing days because, again, we got to learn about some of his activities outside of the fire service. And if you've ever watched the speedboat races, he had a large impact on that. And I can just imagine him being out there monitoring the races, but probably even more so, probably drinking a beer, hanging on to the back end of it and bouncing around on the waves of South Florida as well. So.
Okay, well, thank you very much. Even though I feel like in some respects, we are trivializing to some extent because of the length of this, what we feel about this whole thing and the impact. So we want to say goodbye and thank you for what you did for us, and your legacy will live on. We'll keep that in mind as we move into next year. And Rodney, thank you for taking the time for that salute. I really appreciate it. So I'd like to now, if that's okay, move over to Perry and find out one of the questions that came up, by the way, before you come on. And we've got our Eagle from Paris there. Thank you so much for always joining in, Pierre. It's really important to us. One question that came up earlier was that there are reports that there were earlier cases in Florida and France in late December that were not recognized as COVID-19. Do you think that's the case, or what do you think? Do you have an opinion about that? Our folks in Singapore said they got tourists that came in on our last call, and they started seeing the first cases the first week of January, so presumptively the end of December. Do you have any feeling that that was the case in France?
Yeah. Hi, Paul. Hi, Eagles. Yes, a quick comment on that. It was observed that one of the patients that was admitted to the hospital very early in January, this patient was still COVID because they have made all the blood samples, and at the time being, it was considered to be let's say, a viral pneumopathy of unknown cause. And then recently, they have tested patients like that because the CT scan of the patient was clearly what we have seen in many patients weeks later. Consequently, it's almost proven that this patient was contaminated, but when and how, it's quite difficult. It seems that it will be in the middle of December, according to the story, and also that the patient has been in contact probably with, let's say, indirect contact with people coming from China at this time, because he was working with a company that has some Chinese connection and so on. However, this is clearly a positive case that has been one of the first in France and not diagnosed. So there is a lot now of questions about that. And in many places where they have taken samples of the patient in intensive care unit, they are also testing other patients. This patient did survive, he is still alive, and his family was also infected, but as far as I know, only his wife. So clearly, this has been extremely commented in the French news because it seems that the virus was in France before we thought it was. That's the key point.
Yeah, okay.
If you want a quick update of Paris, and can I make it now because I have to go back to the French meeting of the region. And clearly, as we said last week, Paris is now in a plateau with a decreasing level. So we have still a lot of patients hospitalized in ICU, about 1,500. And we have also about 10,000 patients still hospitalized. But if we consider the call to the EMS, we came back almost to the normal, considering that we have still 20% of calls and ambulance run related to COVID. So COVID has not disappeared. However, it's not at all what we had in the past week. And clearly now, the discussion in France is that the government has said the lockdown will be released next week, will be stopped in some places and partially released in others. So we have a map with the red zone, as you know, and the north of France, the Paris region, and the east is a dark red, we said. So that will be only partial deconfinement in Paris. And we are working on what we have to track the patient in the city, also to connect them to care and to organize care at home for this patient with the possibility to have a mobile team dedicated to that organization sent to the patient anytime as needed. And the EMS is in backup, in fact. So if the patient has some severity, sign or infection, indeed, it will go back to the system of the EMS. So this is a lot of work considering the number of patients that may be included in such a system, and it's organized by the government with the professional, and we are working a lot about that. A word about retirement home. Retirement home is still a problem, but we have made a lot of things also in terms of mobile team that goes, as we discussed last week, mobile team that goes to the retirement home, and we have good result by now in these places.
Okay, good. And just so you know, everybody, it's just fantastic because Pierre has been constantly here and been a good, loyal person and giving the reports here, and I appreciate it. He and I have known each other for, I guess it's getting on to be almost 4 decades now, right? And he's been at this job for quite a while. And that shows you a lot, not only of his knowledge but his political skill, but I think it just his interpersonal skills and his ability to have the right data for his people. And actually, you represent the emergency medicine, so to speak, at the French government level as well, right? And
Yeah,
that's been helpful.
yeah.
You can influence some of the people there in the Ministry of Health, correct?
Exactly, and we have a lot of contact, and we are discussing a lot with the government at the national level, the regional level, and we have a very good contact in that. The information is circulating very fast between the authorities and the professional, and we are working very hard in order to improve the system.
So it's interesting. Thank you so much, Pierre. That's fantastic. So one thing that we are hearing is that maybe we're thinking the same things in California. For example, reports coming out of San Jose and others cases in which maybe people did have a contact maybe as early as December or January anyway. So we're going to be looking into it as well. We're interested in hearing what you find out eventually. By the way, what's happened over in Mulhouse, over in Alsace? Is things better there where that you had the outbreak?
Yeah, as you know, my friend, the chairman of the EMS system for the nation is in very near Mulhouse, is in Metz, and the east is better now. They have still a lot of patients hospitalized, but as in Paris, let's say, with 8 more days of evolution, they are returned to normal level of call and EMS run in the east of France.
Good. Okay. Thank you so much. John Kramer, before you have to get off, or I don't know if you have gotten off already, anything else then from your end, or you want to mention, or we just know particular reports today, as you said before?
Yeah, no significant updates on anything, Paul. We're continuing to track the PPE issues. There are a number of high volume decontamination systems that are being distributed around the country. There is going to be a small group getting together, hopefully later this week, that's going to look more closely at rural and frontier issues.
Yeah.
Surge capacity, both healthcare and EMS and public health. So we'll be part of that. But.
And Ken Shepke, you guys are looking at similar things with the rural hospitals and some disparities there. Is that correct in Florida? Or I don't know if you're there, Ken, or not. I hope you are. Maybe having to unmute or whatever.
Yeah, sorry, Paul. I had to step away and was involved in a couple other things. But just repeat the question you have for me.
Yeah,
Sorry.
the question was just related. John was saying they're looking now at rural versus urban, and you guys are looking at the problems with the rural hospitals as well, correct? Is in the state of Florida, or not rural, but non-urban?
Yeah.
I guess, so, correct.
Yeah. Well, I'll just speak that for one particular rural hospital I happen to be looking at today. They're smaller, and I think they were a little delayed in getting the coronavirus outbreak, but now that it's hitting their community relatively hard, they're starting to become overwhelmed. And one of the problems we're seeing in this particular population is they have a large population of non-English speaking people. And so now we're working to make sure that all the educational messaging is going out in every language that could possibly be across the state of Florida. We've been working on that already, but now we're really concentrating on this one particular community that's very rural, but these folks were still having mass gatherings for religious reasons and for funerals, and now we're seeing the outbreaks that come from that activity.
Yeah. Okay. And that's kind of what we were hearing. It was predicted a few weeks ago by by Mike Osterholm, that they would stay, as he put it, the blue states to the red states, but it's the same. It's the concept that the smaller communities are probably going to have the impact here now. But at least we've had a heads up on that, and that's really helpful. Okay.
John and Paul, Jim Augustine. I just came off the IAFC conference call, and it was exactly the same issue. And the potential for having to use intrastate and interstate compacts to get the resources out to communities that have a lot of our processing of, for beef and poultry and pork processing. Those communities, Gallup, New Mexico, got hit really hard. So all of those are really important and were an issue for our fire chiefs as well. John, thank you. And Paul,
Exactly. Yep.
That would involve us, obviously, if we have to clear protocols and so on, but there's regulatory things. So we're going to need to coordinate well. And for those who don't know, John is the director of EMS, the Office of Emergency Medical Services at the National Highway Traffic Safety Administration, and our key person in the federal government representing EMS. So thank you, John, for all the work you're doing. And we'll see you tomorrow, correct?
You bet.
Okay,
Thanks.
thank you so much. Hey, Fiona, you're over there in the UK. Tell us what's the latest in England, okay, if you don't mind. You have a prime minister that got over things, but are you over things?
So yeah, the Prime Minister got over it, and now he's a little boy who's been named after two of the physicians who looked after him. So, and his grandfather as well. So things have plateaued in the UK. We've still got a lot of people in hospital, but certainly from our point of view, the call volumes have gone down to, well, for us, 6% below normal, which has been really beneficial for our performance and for our patients. What we have seen is that people are frightened to go to hospital, so the number of STEMIs and strokes has gone right down. We've discussed before the impact on cardiac arrest survival. So we are now, we've got a campaign going, Help Us to Help You, to persuade people that if they have a serious medical emergency, they must call for help. And if we advise them to go to hospital, they need to take that advice.
Yeah, that was a call. On a call I was on earlier with, in Florida, was that we were having a lot of cases, people like your next door neighbor, I think in Peter Antevi's case, that just wouldn't go in, even though he was trying to convince them. So part of, I think, our PR thing has to be, and I know many of you have already made attempts, is to make it sure and make it clear that the hospitals have set up a split arrival area, and maybe that has to be coordinated with EMS, that we know we can tell them with good faith that you won't be going into a main area where there might be exposure to other COVID patients, that you're going into a separate lane where it's done and everybody will still be protected and you'll be safe. We've got to manage this. So I guess we may need to do a better job of that, and or in all of our jurisdictions, as well as make sure we're coordinated with the hospitals and our transport dispositions. Have you done anything like that in your area yet, or any kind of public announcements about it, Fiona?
Yeah, we have red and green areas in hospitals, red and green areas in the EDs. And we are starting to try and pick up elective surgery, having taken over the private hospitals, because one of the real impacts on this is going to be on cancer. So most of the cancer screening has stopped. Nobody's having a colonoscopy these days, or an upper GI endoscopy because of the risks. People are not going for their routine scans. There's a limited amount of elective surgery going on. So certainly our colorectal surgeons reckon it's going to take them 12 to 18 months to get back on track.
Yeah. And we mentioned this before, that there are so many other aspects of collateral damage, so to speak, that will occur. Not only people, maybe more cases of CHF showing up because people had their heart attacks and they weren't stented quickly enough or whatever it may be, or the permanent damage from the stroke that they suffer, but there may be kids not getting measles vaccinations or whatever. There's just a whole host of things that we'll have to stay on top of here. So I think we do need to have some opening up. So I guess, especially on the medical end, I think that is a necessary business. But hopefully that we won't let our guard down in terms of, now that we know what to do in terms of protection. Any other, yes, go ahead. Who's that?
Yeah, this is Peter Antevi. I'm just wondering, has anyone, does any city have a hospital that's dedicated to non-COVID patients? Are they doing that at all? I'm just wondering. I haven't heard of it, but I thought it'd be maybe a good idea.
So you're echoing a lot, Peter, but if you hadn't heard him, what he was saying is that, are anybody having systems in which they are having dedicated non-COVID hospitals versus a COVID hospital, or probably, I don't think I've heard of any dedicated COVID hospitals except for in some places, but anybody have a non-COVID hospital? Because I don't know if there's such a thing you could have, but you could at least advertise it as such. Anybody having that or doing that or aware of that?
So that's what we've tried to do, Paul, with the private hospitals.
Yes.
So public hospitals, no, they do red and green, but the private hospitals, you get tested on arrival. And so I guess they're trying to keep those clean.
What kind of testing are you using there? Because I'm still concerned about the validity of our testing. I mean, not so much validity as, but the false negatives because you got there too late, or or just the incomplete technique and all that. I'm always still concerned about that, but I guess it's just a relative risk. But what kind of testing are you using?
So we're still doing the antigen testing. For symptomatic patients, we try and test them at day 3 or day 5 at the latest. We're doing a study in 11 hospitals across the UK, testing all patients and staff to see what the asymptomatic rate is.
Right.
But
exactly.
the evidence would suggest that even the self-testing is safe enough. I was a bit skeptical about that, but the evidence would suggest it's as good as having a healthcare professional ram a swab up your nose and down your throat.
Yeah. Okay. Got it. Or as we call it, the brain biopsy sometimes, if you had one. So, all right. Let's see. So thank you so much for the report, and thank you for being here. It's great to see, and I'm glad you're well, I assume, right? So, okay. And everyone in your home. Okay, so let's then move on to a few others here. Let's see if someone I wanted to catch up with is Ed Rock. And Ed, so Ed's responsible for about 38,000 paramedics across the United States with AMR/GMR, Global Medical Response. And Ed, anything that I need to know about from your ends, because you are seeing smaller cities and as well as the support in the large cities. So any main message or findings that you're bringing up at this point in time?
Yeah, good morning, everyone. By the way, nice to see everyone, or afternoon for some. A couple things, Paul. One is kind of surprising to me, to us. We, like everyone else, overall, about 5.5 million transports a year. We were down about 32% at the peak of this in terms of volume, like everyone else is. Interestingly, and I'm not sure I can connect the two with reopening, we are rapidly, in the past 5 to 7 days, the volume nationwide has increased. So whether that's related to, as we've all talked about, folks who are less hesitant to seek medical care, whether elective surgeries, whether all of the healthcare system dynamics are at play, a little bit surprising, frankly, from my standpoint, that it would be increasing that rapidly. Two is,
it may be part of the general mentality that it's okay now. That sort of the signal that's being sent out from our elected officials is that we're over the hump, kind of, or we're going downhill. And I think that maybe that's part of it. But again, that could have a negative impact as far as the general public. So, but go ahead.
No, I think you're right. And I think, to that end, and per the previous discussions, we're seeing more and more hospitals nationwide that reach out to us to say, what do you guys need to feel comfortable? It's actually a nice partnership, to the point of, Are there parallel passive entry into the ED for patients outside of more of a heavy COVID response interval, including, and I'd be interested if any of you all are doing this, online medical consultation seems to be increasing, where physicians or hospital staff will talk to patients who are reluctant to come in. So we're starting to see healthcare providers at the hospital. So for example, someone's got chest pain, they've got a STEMI, they don't want to go in, they've got a COVID concern. Healthcare systems are actually saying, look, use online medical consultation, get a physician or a clinician involved to help the patient feel comfortable and not make the wrong decision to not approach the healthcare system.
So that brings up a good point then, Ed, that maybe we should be also helping with the messaging and coordination with, like, say, medical societies, local medical societies and health, let's say the hospital associations, that they will be safe. There will be whatever red zones, green zones, or whatever we want to say, where they could be okay. So that's great, because that helps percolate some other places we can make sure we message, as well as the media. Okay, go ahead.
No, I think you're right. And I think medical directors in those communities are key, because there are so many different incentives out there from healthcare systems, emergency medicine, EMS, medics themselves. So to have someone that kind of takes control over that consultation, what the appropriate messaging is, how those contacts go, I think makes good sense. Like everyone else, we're starting to see an increase, as in the Gallup, New Mexico, an increase in target populations now. With meat packing plants, I had no idea, by the way, how many meat packing plants there were in the U.S., but there are gazillions. So we're going to the good steaks places first, but they really need guidance, clinical guidance on how to appropriately manage. So a lot of them use consultants, obviously, but that interface between their particular plant or their community or their tribal nation and the healthcare system really is key. Only other two things: we have 167 positive employees throughout the organization, COVID positive. Unfortunately, we've had one death, and we have one who's in an ICU on a ventilator. The rest are doing okay and are at home, no other hospitalizations, but we did start breaking it down by employees. So it's about 57 are paramedics, 83 are EMTs. There's a flight nurse, 5 are in communications. And that was, and Andy, you and I had that discussion a while ago. Those are really potentially worrisome conversions, given it could wipe out literally an entire communications center. 2 of them are pilots, and then 10 are other support staff. Because of that, today we're actually implementing, and I'd really be interested if anyone has any other thoughts on this. It's so hard to determine with reopening, with the variability in what both antibody, PCR, repeat PCR, viral fragment persistence, what all that means, that we made a decision that when you come to work, and when you're at home, probably you need to have facial protection. So we've graded it, and essentially from the cloth mask, the non-patient care areas, even folks like mechanics, VST folks, we've just made a decision that everyone needs to be during this time period, instead of trying to sort out whether they're in a high potential contamination area or not, that the cloth mask, the surgical mask, and the N95 based on risk stratification makes good sense for us at this point. There's too much unknown in the community that surrounds our folks, and frankly, a big chunk of, again, as Andy knows, a big chunk of our employee conversions probably spent a fair amount of time asymptomatically inside of the work care environment before we knew they were positive. So that's kind of the new journey, is figuring out how to keep our folks safe as testing evolves. Pretty encouraged by the Roche approval test, and hopefully we'll talk about that as well. So that's kind of it.
Yeah. So Ed, I kind of am leaning towards what you're doing. So I do thank you for that comment, because we really don't know altogether, first of all, what the tests absolutely mean. You're not protected just because you have antibodies, and it may not be the right antibodies or whatever, or it may not even protect you in the first place. So until we know a little bit better about this, I would just stay on guard. So I really like your approach to this. So we'll see. There may be some new promising antibody tests that are coming out, both which sounds like the sensitivity and specificity is up with out of, I think one was, I think, Roche, and the other from Abbott. So we'll just see. Hopefully they'll be available. And I don't know if that will change things, my opinion about what to do, but I like what you're saying. And by the way, some other cities are, and unless there's anything else, I thought I'd go over a couple other cities are doing things. For example, Joe Holly, you're thinking about doing rapid tests right on the scene, correct? Is that correct right now with patients and family? Joe Holly from Memphis, our Eagle from Memphis. So can you hear me? I'm maybe giving him
No,
some
I hear you, Paul.
Yeah, go ahead, Joe.
Yeah, so we've just been noticing that, in addition to our call volume down about 10 or 15%, that the non-transport rate is way up. And in trying to dig into that a little deeper, it seems that the primary reason for that is because the family member can't go to the hospital with them. And so our thought was, as these antibody tests, particularly the rapid turnaround tests, become more available, might we consider not only testing that patient, but the family member that wants to accompany them to show that they are negative in order to relieve the hospital's concerns. Obviously, we have to get consent from the hospitals that they would still allow the family member / visitor to accompany the patient, because they've almost all completely banned visitors in the ED. But I am concerned that lack of family or visitor accompanying that patient may be keeping them out of the ED.
Yeah. Okay. And then, so that's great. By the way, while I got you on the phone, anything new happening in the Memphis area? What's any either specific or broad observations that you're making?
No, nothing really dramatic. Our numbers continue to increase in a fairly linear fashion, but we have not yet reached capacity, and I think that's given us an opportunity to complete our preparations.
Okay. Hey, and then John Jew, out in Portland, are you actually using the emergency department folks that you work with to do triaging as well, correct? And how are they doing that? Are they using any particular platform or just talking on the phone?
Yes, so we're doing about 2 or 3 things. We actually have taken the Emory website and actually what we call c19oregon.com. And we're actually stratifying the answers into trying to identify where they're at. But what you're referring to is our nurse advice line, the Oregon Health and Sciences nurse advice line. It's correlated and connected with a 211. And they're basically giving free nurse advice and stratifying concerns and issues there as well. So that's available statewide to our citizens in Portland and Oregon.
Okay. And then Garth Gamer out in Phoenix, you've tried to do some of this yourself, as a matter of fact, in terms of talking to people out there. I guess you and some of your other doctors, right? But you're not having much luck. Is that correct, if I remember?
Well, it's kind of crazy what we've been doing here. It's we have a 24/7 online medical direction service, and people are, during the height of this, were calling with this solitary ask is, am I going to die within the next 48 hours? No, I don't care what I've got. I don't want to go to the hospital unless I have to. And people were having chest pain that was clearly anginal, EKG changes, stroke-like symptoms, and refusing to go to the ER. I would get on the phone and tell people, you're probably having an MI. You're definitely having a stroke. Well, am I going to die in the next 24 hours? No, but maybe in the next 48, you're going to. So the message, we've got to get out with public service announcements and tell people that EDs are safe places to be. And we're trying to face up to that right now. But that being said, volumes are inching up a little bit for Phoenix Fire and agencies around here. So maybe the problem's going to take care of itself as the state opens up.
Yeah. All right. We'll see. But yes, the messaging is there. And that's what we've seen in the past, by the way. This is just kind of interesting. In the past, years ago, when we try to do the things, don't call 911 unless it's an emergency. You always have to say unless it's an emergency. And oftentimes that has backfired where the number of calls went up for 911 and yet the stroke people or whatever stayed home. So we're back to sort of things are more the same today than they ever have been, as I think Dwight Eisenhower once said. Chris Sauter is down in Houston. You guys aren't really seeing the same problems. Maybe you're what's happening on your end there?
Yeah, no, we've had a steady decline in terms of the community hospital admissions, general and both ICU. That was at its lowest on Friday, and we've had about a 6% jump in admissions since Friday, since the state reopened. But that's still way less than the normal percentage of ICU fulfillment before this started. We were normally at around 85% to 90% full. We went down to 78, now we're up to 84. So we're still pretending like it's not here, apparently. So.
Are you at all, are you doing anything public relation wise or media wise or communication wise to tell the public to come in, if they are having a heart attack? Are you doing anything actively that way, or is this sort of taking care of itself?
We are not, there's no public thing along those lines. There's a fine balance between the governor's statements and our local authorities of a different political party to subtly disagree with him. But they are not going out and saying, remember still to call us for X, Y, or Z otherwise.
That's interesting then. Okay, thank you. Yeah. Hey, Brett Myers, I saw you're there. If everybody knows, Brent is a past president of NAMSP and now the head of ESO. You guys are collecting a lot of data on this. Is there any particular findings that you have for us or anything you want to pass on to us? I know, Brett, can you hear me, Brett Myers? Well, if not, pipe in anytime you want, just if you can't hear me right now, or if you're, you may have gotten on another call or distracted. So then let me go ahead and go over to Jim Augustine briefly. Anybody else have anything they want to comment on before? I may go around the room later to everybody, but I wanted to see if you had any particular, anybody have anything along these lines that you wanted to pipe in on before I turn it over to Jim Augustine. Okay, with that, Jim, you want to tell us about some of the reports that you've been going over the last couple of days, and we may talk a little bit about the positioning issue maybe last, so if you want to leave that to the last one, but what are some of the other reports that we got? And first of all, let's talk about if you have anything from the IAFF and IAFC, the Fire Chiefs Association, as well as the Firefighters Association. Are there anything new that you have from them beyond what you just told us before? And then can you tell us a little bit about our, our recent surveys of the Eagles?
Yep. Thank you very much. And thanks everyone who's been contributing. We've had unprecedented responses to the surveys. Interesting on EMS education and riders, that's going to push back EMS education for a couple of years. We're going to have to maintain the pathway. And of course, the EMS pathway for careers also leads to a lot of careers in other services as our members move up into nursing and physician assistants and physicians and respiratory therapists and other things. So it's a shame we're not at the point where we can incorporate students into our ride-along and other educational programs. The issue in front of the fire chiefs and the firefighters, the recurrent issue of testing, of course, but they're worried about a couple of things. One is the impact on the smaller communities of this next wave. Number two is being able to build up resources for a fall outbreak when budgets have been decimated. And many of you know local and state governments cannot borrow in the same way that federal government can and mint their own money. Therefore, many significant budget shortfalls to begin with, a demand that they cut their staff at the point where they should be focusing on a fall outbreak and the potential to build up PPE and other things. So we should all be aware of that, and it's going to hit all of our locales, and we as medical directors will have to be part of that discussion. The International Association of Fire Chiefs has implemented an economic impact task force. And again, the chief and others have been very, very active in appealing to the federal government for relief for the entire service. Second, building up vaccination programs and thinking at some point we will be part of the vaccination response and need to make sure that we're ready to vaccinate if needed. Most states have been permissive in their approach to this. I appreciate everyone's responses to some of the other non-COVID surveys that we have done. And it will be our opportunity to continue some of those discussions over the summer. But a lot of this, Paul, is prep, and Mike Osterholm and other people's contributions, how we do messaging to our communities through EMS and make it consistent with our government officials will be really important. And I think a lot of people are tired and they need to take a little break this summer, and I think that's important for all of us as well. Thanks for the opportunity. We'll discuss proning later. Paul, thank you.
Okay, good. Well, it's probably not a bad time then just to pivot into the proning since you've already brought it up. Tell us a little bit about what I guess the question is, do people use proning? I think that was a specific question, and I guess that's lying on your stomach, kind of, that true prone position as opposed to side position or whatever it might be. And in that respect, I guess that was, we were talking about in terms of EMS, and I don't know if we separated that in terms of interhospital transports, in terms of someone already being intubated, or how we do it when we transport. Can you just clarify that one, then give us what you found?
Yeah, it was very clear that people wanted to discuss the EMS version versus the interhospital and later care version. And so Ken Shepke was nice enough to say that he was advocating for proning. Many other people had concerns, as I do, that we do some simple interventions first and see how they work before we flip people around. Number two, a lot of our stretchers and safety systems in the back of an ambulance are not really made for people who are prone. Third, that kind of that unconventional position puts other things at risk in caring for the patient early in the operation. So it is very clear that people who are doing MICU and hospital, in interhospital, were using proning, maintaining that position after patients had maintained some stability in the first emergency department. So that was uniform, and Ken Shepke, thanks for voicing the alternate position for that.
Yeah, so
yeah, it's no problem.
Go ahead.
Paul, I was going to say, I think my actual thing was flip them like a burger, folks, right? So this is a relatively simple thing, and it's something you can rapidly undo. And it doesn't, while we say prone, we have to understand that lateral works as well as being being in the prone position. So, and from reports from our colleagues in the ICUs and the emergency departments, you can literally see rises in O2 sats within minutes of changing the position. So I think it's very simple. You don't need a whole lot of special equipment. It's free and it's rapidly reversible if you decide, hey, I don't like that position, just flip them back.
So Ken, this obviously applies to one, people who are desaturated, let's say less than 90% or whatever it might be, and two, people who are maybe symptomatic, or just, are you just going for the number there?
Repeat that. That cut out for a second for me there, Paul.
So listen, so all I was saying is that, one, is this applying theoretically only to the patients that we see are desaturated, let's say, I don't know, under 90 or something like that? So, and then, or what if they're asymptomatic? Do we still try that, or do we try oxygen first, and then maybe then if that doesn't work, we go on to the positioning?
All right, so they're all put on oxygen, and the criteria is you have to be awake, good mentation, cooperative. You can keep the oxygen in place as you change the position. Those are all preconditions in order to do this. And obviously, if you improve oxygen, you don't need to do this.
Yeah.
But if even after supplemental oxygen, you're still low O2 sat, it's a very simple thing to say, hey, try rolling on your right side or your left side or even on your belly, but let's just keep that oxygen in place when you do that.
Okay, I get it. So, so for the most part, probably when we're doing transports, it may be easiest to do, whatever the usual position. But if this is an attempt, if we have to treat him in the interim, to do that, and we were talking about our primary transports, not inter-hospital transports, but maybe that's applicable there. I know that a lot of your approach to things has also come from our colleagues in the ICU, like David Farsi. I don't see that David's here today, and Scott Weingart, for example. But Lauren Maloney, you're Scott's fellow, and can you tell us a little bit about what the approach there? Because I've heard it's more of a, I'd hate to be rude, but more of a rotisserie approach, sort of what Ken is suggesting here. Are you there, Lauren Maloney?
Yep. So we are, we're using the self-proning technique. And so basically we have a piece of paper that helps to remind providers as well as, patients every 2 hours, changing position from left lateral recumbent to right lateral to sitting up 90 degrees if possible, to prone in bed if able to. And we also have been providing discharge instructions that are in Spanish and English that have pictures involved on the actual positions to patients that are well enough to go home, which seems to be helping based on when we call them to see how they're doing on follow-up.
So you guys are actually seeing some improvements when you do various positioning. Is that correct? You're talking specifically, though, your experience in the emergency department as well, correct?
Correct. Yes, and absolutely.
Do you have any advice for us about trying the same thing as Ken was suggesting in the pre-hospital arena?
Well, I think it's reasonable to try the lateral recumbent positions, right, left, and move slowly, I guess would be the other key.
Okay, got it. Well, then thank you, Lauren. And by the way, how are you enjoying your vacation? Where are you, in Hawaii, or where were you going?
Yes, nice staycation, getting some yard work done. It's been delightful.
Okay, good. Well, great. Thanks to hear from you. So then, Keith Lurie, you're here. You've done a lot in positioning. You know a lot about it, particularly in cardiac arrest cases. I don't know if this is applicable here, but anything you would add to the mix here? Because you've certainly shown that, particularly even after return of spontaneous circulation, that the brain oxygenation goes a little bit better if you have them in a somewhat, what you want to call it, a semi-Fowler's position. I don't know what you go. And we have Fowler on the phone. I wanted to see if we can say if there's such a thing as a semi-Fowler. But having said that, Keith, you want to take over, and any thoughts about this, or you could give us, since you understand the physiology of positioning for the lungs as well.
Sure, thank you. Hi, everybody. I actually hadn't thought a whole lot about positioning until a colleague, Lee Glickman, who's a emergency room physician and cardiologist in New Jersey, called me up several weeks ago and said, I'm about to go on shift, and should I keep the patient prone when I do CPR? So I think that everything we've heard from Ken Shupke and Lauren and others related to proning when oxygenation is challenging is true as long as the patient has a decent blood pressure. And the studies for ARDS patients have shown that if you have a mean arterial pressure of 65 or 70 at a minimum, then you can afford, from a cardiovascular perspective and circulatory perspective, put them prone and increase the amount of oxygen saturation by effectively changing the distribution of gases in the lungs. But the question then is, how about if somebody is going into cardiac arrest? Should you keep them prone, or should you put them supine at a minimum? There's not a whole lot of data on that. There are a couple of case reports from neurosurgical patients in the operating room where somebody has come back. But this question from Lee, and then a little discussion further with Paul, prompted me to think further about this. And I think doing CPR in the prone position is actually very bad. When you push down on the back during CPR, then both the chest and the stomach and the abdomen get pressurized, and that's immediately going to pressurize the venous blood going up to the brain, and so you're going to increase your ICP, disproportionate to for sure if you are supine. The other issue is that the challenge with CPR, whether it's manual CPR or with some of the advanced technologies, is that you've got to get blood back to the heart during the decompression phase. And the blood is actually going to pool in the belly and the splanchnic bed, and anywhere it can, it's going to be very difficult to get it back to the heart. So if you see somebody who is in cardiovascular distress with a falling blood pressure, I would think that even if they're oxygenating better prone, make sure you can rapidly rotate them if you think they're going to need CPR. Obviously, that's a situation where somebody is really an extremis, but those are the situations where you potentially have to sacrifice a little bit of oxygenation for circulation, and circulation will be better in the supine position.
Okay, great. Well, thank you for being there. So I think we're getting a better vibe about what to do here. Part of it is maybe experimentation, and but for sure in a cardiac arrest situation, it may be a whole different deal. I like the idea of it has to do with the blood pressure that you're getting at that point in time. Pierre, Carly, are you guys doing anything different over there, especially since people like Gattinoni were some of the first to describe this for ARDS, and so it's been going on in the European continent for quite a while. So Pierre, if you're still there, can you just comment about, are you doing anything along these lines? One, in the emergency departments or ICUs, and two, in the pre-hospital transport?
Let me say precisely your question. You want me to do what about the transportation of the patient ERDS?
To say about this positioning, the prone position versus, do you do experimentation to see what position they're best in? Sitting up, looking down, or how do you? What is? I was just saying, in Europe, it's very common. You guys came up with the concept years ago, and so I just want to know how that's playing out for you there.
Let's say that in intensive care, you need the prone position has been used extensively at the beginning for several patients. That means a few hours of prone position and then back to the normal position. During the transport of the patient, we do not have used prone position. And when we transport the patient in the train, because it was quite difficult to move the patient back to the normal position and to the prone position. At the time being, the patients that are in intensive care, the prone position is not working in all the patients. So they test it, and if it works, they do it. And if it's not the case, at the time being, we have also several patients that are with ECMO. And some of these patients has been on ECMO for a few weeks. So that's a lot. So it's quite difficult to see what is working. We don't have a precise management, let's say, protocol that suits all the patients.
Yes.
We have to adapt it, and we have a lot of toolbox that will be tested.
Yeah, I think that's the general conclusion I'm hearing from this today. So that's helpful. I just want to make sure I didn't miss anything over there. Hey,
it's AJ.
Yes, go ahead. Yes, AJ.
I just sent to Jim Augustine a really nice protocol from Arlington County Fire Department, Dr. Reed Smith, on prone positioning that they use, and he can share that with the group. We're going to be talking about it on my EMS Today show on Friday. I think Ken's going to join us and a few others. So he can share that protocol. Very easy to follow and makes some sense.
Okay, thank you then. Just what's the summary of it though? Is it to talk about go to prone, or is it to try different positions as Scott Weingart and his group would do? Or
yeah,
what,
he has
what you're suggesting. Yes.
He has an O2 sat of less than 95%. Place the patient on 4 to 10 liters, and if they've got that sat, then transport. If they don't, then do a wake prone positioning, and then it follows from there. Very easy to follow.
Okay, got it. And I like the idea that Ken was bringing up was a little bit about the, not Ken, but Keith was bringing up about looking at the vital signs. That was an important part of it. All right, so let me take that.
Excuse me, what people are doing is they're using either a combi carrier or a scoop stretcher and have the patient secured so they're very easy to put on their side. And there is a strap system that can attach to the overhead grab rail to help with the weight shifting.
Okay. All right, so then,
can I join in on this topic as well?
Sure, Craig.
Not to belabor things, but why is there a reluctance, and why are we trying to make this difficult? Again, it's all about patient selection. Patients sleep on their abdomen all the time without monitoring and things like that. I don't understand our gurneys not being safe to do this. If we have pulse oximetry, cardiac monitoring, we can visualize the patient. We maneuver patients and change them if there would be a sudden decompensation for anything. Again, anecdotal experience is all I'm talking from, and there's quite a dramatic symptomatic improvement in a majority of patients. I wouldn't say all, but that's from feedback from our medics who are out there. We have some initial data that suggests that there's improvement in oxygenation at least. And so I just, I'm having, I think we're trying to make it a little bit more complex than perhaps what it is, but it always comes back to patient selection and trying to find the things that may be helpful for us. And so,
yeah, I think that's my takeaway as well. Don't make it too difficult. Just consider this as an option that we usually don't, to see if we can improve oxygenation, if that's the case. So thank you. That's a great comment. Hey, Brent Myers, are you still there by any chance? Are you back? I was calling you before.
Sorry, the phone rang and I had to step away. Sorry.
No, no problem. Hey, so Brent, what I was asking is that I had introduced you before, you know, as one of our past presidents of NAMSP, and also the head of ESO's operations, and you guys are looking at some data related to EMS. And maybe briefly just say, you know, who you're collecting data from, and secondly, what your findings are.
Yeah, sure. Thanks. So we have about 1,800 agencies that voluntarily share their data for research and benchmarking, and literally an hour ago just submitted our first peer review to PEC that looked at the first 800 hospital confirmed cases across all of those different areas. And the take home is not surprising. Compared to the general population, they are about 4 times as likely to be hypoxic, 4 times as likely to have a respiratory rate above 20, 4 times as likely to have a fever. The really nice thing about it is EMS sensitivity for noting the suspicion of the disease once confirmed was about 78%, and the positive predictive value was 20%. If they said this patient has COVID disease, 1 out of 5 actually did at the hospital. So EMS really has started getting good histories and having a high level of suspicion. So we're actually cautiously optimistic that as this goes on, EMS is going to be identified better and better.
Yeah, okay. Thank you so much. Thanks for the great work you're doing. I'm really anxious to see how that turns out. And thank you for participating as well. And while we're at it, in terms of broader systems, Emily, you're there. You have the Texas end of Acadian, right? And anything new to report from that?
No, I mean, from an Acadian standpoint, what we're seeing is similar to everybody else. We had a significant drop in volume, and like Ed was saying, we're really starting to see a rapid increase in our call volume, which is good. We also have noticed a significant increase in our refusals. We also have online medical control always available, and we're really encouraging the medics to use that more to try and, you know, decrease our refusal rate. As far as Texas goes, like everybody else, we're having a huge push on testing. The state has really been focusing on some of the rural areas and counties that didn't have access to testing up until about the last 2 weeks. And so while our death rate, fortunately, is continuing to drop, we're gonna, you know, obviously expect to see a significant jump in numbers of cases just because of the numbers of testing we're doing. And we also in the state are seeing a huge push on testing in nursing homes as well. We're actually doing that in areas that can't handle it from a local public health and local EMS standpoint. Our Texas Emergency Medical Task Force, which is our state kind of deployment team, is actually going out and helping with some of those nursing homes. That's about it from us.
Okay, thanks. So I'm going to try to pick up around the country, especially people we haven't talked to for a while. So Armando Clift works with Paul Adams down there, our Eagle. So he's our eaglet over there in Miami. And anything report from Miami, because you were a hard hit area, especially up front, Armando. What's going on there?
Yeah, fortunately, we were never hard hit to the point where our hospitals were on overload. We always had ventilators available. No one ever went on diversion. We've been actually seeing a decline just on first look on the data, but we were on a call with the Department of Health and some epidemiologists yesterday. We finally were able to get a consortium together just to kind of go over the stats here, since we weren't really getting a good bite from epidemiologists in the Department of Health. And we actually kind of got them to tell us that it does look like we're on a downward trend, at least in the last several days. Couldn't really, the last 2 weeks, even get a really statistically significant downward trend. But yeah, we're running about 9 anywhere between like 7 and 9% positive COVID rates in the community and hospitals here in the county. And then similar numbers when we do our mobile testing with our paramedics out in the community for patients that don't have transportation to get to a testing site. We're seeing about the same positive hit rate for those.
Okay.
As far as deaths and things like that, it's a little hard to tell. Our county medical examiner doesn't seem to be actually testing all of the dead on arrivals that go to the medical examiner. So we don't really have a good idea of how many deaths are caused by COVID. We have seen an increase, and this is the one thing significant difference we've seen, is that we've seen about 40% increase in dead on arrivals from March 1st through currently compared to last year at the same time period. And that's been a concern. We don't know if those are from COVID or strokes or STEMIs or,
And you've heard from the different cities like Cleveland and Seattle are actually testing those and bringing them back there. So maybe it's something you can learn from. Hey, listen, I wanted to, but I need to get onto some of the other cities, but anything else you can add or anything that you guys have changed or anything of particular note?
No, we really haven't changed anything yet. We still have our, going on our 36 MPDS pandemic card. But nothing's really drastically increased or worsened.
All right, good. I'm gonna talk to Lakshmi in Atlanta pretty quickly, but first I thought I'd go up to Philadelphia, since you're in the near New Jersey area, and Dr. King's report to see, well, how's that impacted you?
Actually, I think we've so far, knock on wood, been spared. Our volume has been decreased like everyone else's. It's starting to creep up, and that's the same with the hospital censuses. And it just seems like people are starting to come out of the woodwork again, and just regardless of official openings up of the city or the state, people I think are just coming out again. And I think that's in part reflected in our increasing numbers. We have a little over 700 deaths in Philadelphia now. Our 250-bed field hospital that was set up at Temple University is essentially closed down now for lack of patients. We're getting enough supplies. I think for the time being, we're doing okay.
Yeah. So let me ask you this. I've heard that the crime rates have possibly gone up and maybe more police action happening in your city. Is that true, or just me hearing rumors?
Well, that may be true. It seems like shootings are going up a little bit. I always keep my police radio on too, just because I'm a whacker, and it seems like that activity is increasing. And certainly we also have the baseline opioid issue here, which has not decreased due to COVID.
Ah, okay. Yeah, that makes sense. That's interesting. Okay, good. Well, listen, thanks a lot. Anything else you could think of before we switch over to the next person?
No, I don't think so. But thank you.
Good. Let me jump over to Lakshmi then in Atlanta. What's going on there? Anything new or anything to report to us?
So our city is leading the pack as far as reopening is concerned. Most places, so they actually said you can reopen, but a ton of places are not quite reopening. So it's been more gradual than expected because they're just keeping salons and restaurants still shut down in certain areas. We are seeing higher EMS volume though over the past weekend. Definitely it's creeping up. There was more penetrating trauma. So crews are getting busier. COVID calls are about the same, not quite decreasing, but we're still getting COVID calls. And I think more people are willing to go to the hospital because they have this false sense of, okay, the city is opening up, it's probably safe to go back in.
Yep. Okay. Well, thank you very much, and for what you're doing. Hang in there. Hope you're well, and hope everybody else in your surrounds are well. So let me jump way over to another part of the country, and to Stein Bronski, because you were starting to have some increases up there in Colorado Springs. What can you tell me?
So our numbers have decreased, which is good. And we're dealing with a lot of what's been mentioned on this when Ed Rock mentioned that our largest issue right now, in a way, is trying to convince people who need to come into the emergency department to come in. So we've really been using telemedicine. Our platform is through Pulsera. to help talk to the patients and visualize patients with the field crews and try to help them understand if they do need to come in, that they do need to come in. And another big thing that we're dealing with now that started a few weeks ago, but we're really starting to see it, is that in our changes in our protocols for the field, especially cardiac arrest and some other protocols that deal with exposure, we're really struggling with the psychiatric or psychological impact on the providers who really feel as though their hands are tied and that they are not able to perform the jobs that they signed up for.
Yeah.
And so we're starting to come up with programs and actually we're lucky enough to have a psychologist on the fire department here who's helped us with programs that we've just put out to help people cope with that and understand that, because I view this as a long-term thing, not a short-term thing.
Yeah, okay, thank you then. And then let me jump over to the birthday girl. Erica, anything new from your end besides the meat packing plants? So what's going on in Kansas City area?
You know, it's interesting because right now our trauma numbers are way up, but we have a very progressive mayor who has made a different recommendation than our governor. And so our mayor has requested that we stay at home. He started that request way earlier than the state and then has extended that request way beyond what the state has recommended. So our city did a really good job at flattening the curve. So right now it's dealing with the politics, exactly what you were talking about of opening up, and in the trauma centers and for our call volume EMS wise, we've actually seen our numbers start to return to normal volume pre-hospitally, but the hospitals as well are starting to improve in volume, which is good because we took a huge pay cut. I don't know if any of the other physicians have dealt with pay cuts across the board. So we'll see what the next couple of weeks hold for us and how this reopening looks. But so far our numbers have returned to normal.
So what you brought up is a very interesting point, because I think we also need to be planning for the future, because we're so focused on this thing right now that with jobs gone, local, if you have state income tax, that's going to be gone. If you're using local sales tax like we do in Texas to support things, that's going to be way down. So I can see job cuts coming, et cetera. And the other thing,
we're seeing cuts on the state side, city side, and the federal side.
So the other thing to anticipate is I just want to reiterate what that made me think about what Jim Augustine brought up before, which is preparing everybody for giving vaccination, because once they're out there, and I remember us talking about this in the good old anthrax days after 9/11, that we started talking about how we might have to do mass vaccinations for smallpox, whatever it is. And so the concept was that as we were medical directors in some states, we could deputize people, including EMTs, and maybe if you didn't have enough public health persons, but we would have the public health people like supervise them, and we could. So I would just start developing plans if you don't have that, or find out what the regulatory things will be in your state. So thanks for alerting us to be thinking to the future, how we're going to handle that up front. And then that goes along with the issues we heard that if we're not producing healthcare workers like we were in the past, along the whole chain that Jim nicely brought up, that's a concern as well. Tom Collins, let me go to you. We haven't talked to you in Cleveland for a while. You've been doing some progressive stuff like getting the nasal swabs for the dead people. And so what else is going on in Cleveland?
Well, our aggressiveness is talking and getting our medical examiner to do that. Actually, I checked with the state early on, and doing nasal swab specimen collection is not within the scope of practice of our medics, and unless it was specifically mentioned in a state order, the state EMS board was not going to allow it. So we actually have to rely on the staff from the ME's office to do
Interesting. Okay, got it. Well, anything else new though in Cleveland that we should know about?
We're about halfway through a longitudinal surveillance study of about 170 of our medics, where we're doing swabs and serology a couple weeks ago, and we're going to repeat it in a couple weeks and kind of see how their exposures change. So I'm looking forward to seeing what that teaches us.
Yeah, what we've heard over the last few weeks is that there are some people that actually remain positive. And one of the questions I was going to ask Mike Ulsterhub, and we'll continue on, and maybe John can answer it. But I don't know if we have an answer. Is that, are these guys, if they're still positive, okay, they're carriers, but are they still infectious? Is one question. And and how many out there are carriers, and especially the asymptomatic ones. So I'm glad you're doing that longitudinal study. So thank you so much. All right, Andy, anything from Seattle that we can add to the mix here? I know Mike's going to give a report to us on Friday about the bystander CPR rate, but anything else new from Seattle? Are things going okay for you?
Yeah, things seem to be going okay, stabilizing a little bit, and we're starting to see ER volumes pick back up. So signs of some recovery at least, so we'll see.
Okay, fantastic then. Then let me move on. David Miramontes, let's go to San Antonio. You guys have taken a really good care of my son down there, so I appreciate it. So is everything, how about the rest of the community? Are they doing well? David, are you there? Oh, yeah. Oop. Something just popped up here. Is that you, David, that you're doing that? Yeah, it looks like David Miramontes up. We just can't hear you vocally, David.
There you go. How was that?
There you go. We got you.
Okay. So yeah, we're doing really well. So we actually have a couple things I'm just going to show you really quickly. So our census in the hospital is stabilized. We actually flattened the curve significantly. We didn't get overrun in ECMO, and our vent patient status is very good. We developed this health system stress score, which is really complicated math, but what it does is it gives us a, red, green, kind of how are we doing, and this allowed us to because our scores have been so low and our numbers have been so low, we were able to open up to elective surgeries. So the other thing I was going to show you real quick is, I know everyone there, like Glenn was telling me, his cardiac arrests were bonkers, and we actually have a very different process here in San Antonio. So let me share this. So in San Antonio, actually, can you see the whisker tails graph?
Yeah, yes.
Okay, ours is actually down. So the red is this year, the blue is last year, and our DOAs did not change. So I think our Democratic mayor and our county judge has really pushed their stay-at-home orders, and we've really flattened the curve. We're really concerned here in San Antonio that because we're opening stuff up, that we're going to get a second wave. And with us expanding testing, as Emily said, we actually have the National Guard going out all over Texas, testing rural communities, unserved areas, nursing homes. As you heard, most of those are MIH medics. They're going into nursing homes and testing everybody. The other thing I was going to show you is one last thing. Is we have a COVID alert process. So we were initially, we were actually cohorting our COVID patients and sharing amongst the 4 hospital systems. So they had to go through MedCom to get a hospital assignment. And those COVID calls have gone way down, and our transports have gone way down, which is good, but we're waiting for the second wave. So we're just hopefully not going to get a second wave with the opening, and we're just going from there.
Yeah. Okay. Well, thank you so much for the report, and thanks for the great job that you guys are doing that are suppressing it. Yeah, I just really appreciate it. So there's only about, if we're going to do this as a 90-minute call, there's only 6 or 7 minutes left. So there's a lot of other people I want to call on. I'll try to do that on Friday. Of the people who haven't talked yet, is there anybody else wants to bring up anything to us? Whether it's anybody else there that's on the line still that would like to bring up some commentary or area before I sign off?
Well, it's Manifold, from the national level, we've talked a little bit about the economic impact that's seen. I think as EMS medical directors, we have to be at least aware, if not directly engaged. The CARES legislation that is out there, some of the relief components that are coming about. If we are not talking about it with our legislators, making them aware of the impact, again, there will be continued long-term problems facing our EMS agencies. And so I would just encourage you to be aware, be vigilant, become engaged in some of the legislative efforts that are ongoing for protection isn't the right word, probably more for along the lines of survival for some EMS agencies that are out there. And so again, just be aware of what's happening at the national and state level. So thank you.
Okay, got it. So yes, go ahead.
Hey, this is Peter Antevi.
Okay.
I have a question for the group. I received a few calls in the last couple of days from you know, I have a private ambulance company that I work with. A patient who needs to be transported from one hospital to another just to get remdesivir. One yesterday got awfully sick, and we ended up transporting the guy, but it seemed kind of crazy that they have to take the person to the drug rather than the drug to the person. I just kind of wanted to get some education here as to, does anyone have an insight as to what's going on with that specific drug with respect to the EUA and why we're transporting really sick patients to go get a drug that may not work?
So I don't have an answer for you. I don't know if anybody else does, but that's an interesting question that we can maybe bring up to the feds, et cetera, to see, because we just need to see how that thing's going to get distributed and where and how fast. And hopefully it's going to be used sooner than later, as Ken's always brought up to us, is that the earlier the intervention, the better results. And there is something to it that may help us out and not just give it to the sickest patients either. So
Peter?
Yeah, go ahead, Peter.
Yeah. This is John Jew. It may be availability of the drug rather than the moving the patient. So the only availability prior to last week was the people doing the study. So the EUA, as you know, is for patients who are hypoxic, not in vent, is 5 days, and those on the vent is 10 days. But the drug is going to become available in the next 2 to 3 weeks, quote, quote, in the United States. So I think it's availability rather than the drug and the EUA that it was used under.
Right, so basically I was told something similar, that only the hospital who's under the study protocol can actually give the drug. So I have a family member, an in-law type of person who was transferred from one Michigan hospital to another. And then this person yesterday was transported to another hospital. So I think you're right, but it's kind of an uncomfortable position to put patients in. But yeah, thanks.
Correct. Yeah. So you guys are still on the phone, Meg and Joelle and some of the other folks, RJ, Ron, and several others. I hope to get to you next time. I think we, unless any of you guys have anything in particular you want to shout out to us right now. Well, let me then at least ask Meg, how are things looking? If you're still there, Meg, can you tell us, are things getting better for you? Because you guys were hit really hard up front.
Well, I think we're definitely getting much better than we have been. We're seeing a lot of stress on our system, but more kind of chronic stress. I think people are starting to maybe emotionally start to feel the things that they weren't feeling during the acute crisis. So
yeah.
While overall, I think the number of patients that we're seeing with COVID have gone down, and that's wonderful. I think we're entering maybe a slightly different time of recovery where our providers, doctors, nurses, medics are all feeling the stress of what we've been going through. So we're just doing everything that we can to support our people. But overall, we're definitely seeing social distancing is working here. So we're going to keep it up a few more weeks.
Okay. Yeah, I'll be kind of repetitive to what I've said before, is that one of the biggest things that comes out in major tragedies is and manifests in different ways, is the concept of guilt. Like, I didn't do enough, or couldn't do enough, and so on. Or, there's people, particularly in New York, watching people die around them, or the people in Milan or Rome. And you felt like you just couldn't do enough, or you didn't have the equipment to get it done, and so on. So I think that's important messaging we have to say, is that understand that that's normal, that they feel that way, but to also help them take that load off of them, and tell them if they hadn't been there, some others would have died and wouldn't have done well. So let's just do our best to make sure people know we care for them, and that's 90% of it, that we're there, and that we've gotten through this together. So I really appreciate that, and it's going to enter a new phase. I think you're absolutely right. So, okay. Anybody else have anything to bring up at this point in time before I switch off? If not, thank you so much, everyone. And again, see you on Friday. Welcome back, my friends, to the show that never ends here. and hopefully get reports from the others that I couldn't get to today. But we did a good job of getting around the world, and let alone the United States. So I appreciate everybody's commentaries today all the way around. Thank you so much.
Happy Cinco de Mayo, everybody.
Okay.
Thank you.